I'm Andrea Madrigrano. I'm a breast surgical oncologist at Rush University Medical Center in Chicago, Illinois. We were early adopters of the Savvy Scout, that I still call it the Savvy Scout rather than Scout. So I work at Rush University in Chicago, and we were early adopters of the technology, and we were just trying to figure out how long it's been, potentially since 2018. At our facility, where breast imaging was and where our operating room was very far apart. And oftentimes we would have to wait till 8 or 9 or 10 o'clock in the morning to have our patients ready for surgery. So it really delayed our ability to start on time and to utilize our OR efficiently. So it really became a need of how do we become more efficient? How do we utilize our OR more? We didn't want our block time being taken away because we weren't using it correctly. When we were exploring different wireless localization technologies, we wanted something to allow us to be efficient. So the Savvy Scout could be placed at the time of biopsy. But we also recognize not every patient who has a biopsy is going to be a surgery first candidate. A lot of women are getting neoadjuvant chemotherapy, and the need to follow up with breast MRIs is really critical in helping us plan the surgery if they can be a breast conservation candidate or not. And unfortunately, a lot of the other wireless localization products have a huge bloom artifact on the breast MRIs, making it really hard for us to establish the extent of disease. And to our operating room, especially with COVID, we all have limited budgets. So when looking at different products, we needed to use the tools we already had in the operating room. We didn't want to invest in tools that were disposable. We are a very green organization, so we want to use what's needed, but we don't want to have a lot of extra rubbish. Well, really kind of a secondary benefit that we were doing it for selfish reasons, but now we're able to put the Savvy Scout in at the time of biopsy. So we're saving women a second poke. So typically we would do a core needle biopsy, put a marking clip in it, and then when we decided they needed surgery to have them come back. We have a very busy breast imaging center, so it's really hard to get people in for timely biopsies and then schedule additional localizations for surgery, so we really have been able to become more efficient in our breast imaging department, getting our patients through more quickly, but more importantly, saving them the stick that they didn't want to have. As breast cancer treatments have evolved, we know not every woman who has a positive node at the time of diagnosis, if they get neoadjuvant chemotherapy, will necessarily need to have an axillary dissection. But we also want to be confident that what we're sampling was truly the lymph node that had cancer in it to begin with, to really get an accurate assessment of the state of the axilla after chemotherapy. So our practice at our hospital is for any lymph nodes that we're biopsying, we just put a Savvy Scout in so that we're certain to tag it in an appropriate way so that we can have a really low false negative rate when we're doing our sentinel node biopsy at the time of surgery. So it's more efficient, one stick, but it allows us to be much more accurate and precise with our surgery. So I am an academic breast surgeon. I pride myself in being able to train residents. And typically the breast cases are done with the second-year resident who don't have a lot of experience in the operating room and maybe aren't as savvy with their operative skills. But really, we really try to map out the location of the Savvy. Once we make an incision, we do a lot of hidden scar surgery so we can either put the incision around the areola or in the armpit or in the inframammary fold, so we're able to really expose the area. We make our cube. Do they get deactivated? Sure. Do clips migrate? Sure. Did wires migrate? Yes. So I would say if you really do some good preoperative planning and kind of keep track of where you are, even if that Savvy does get deactivated, usually you've already had your whole specimen already delineated, so I don't really think it's a big deal. So some women have larger breasts and have broader spans of disease, so we have been using the Savvy to bracket. Sometimes it's a little bit tricky to kind of find both those Savvies, especially if it's in an anterior or posterior and they're on top of each other. So having two different signals will be able to help us plan our excision, especially if reductions are being done at the same time, because you really want to make sure you get negative margins at that first case, because once the tissue's been rearranged, it can be confusing. So I think it'll allow us just to be more accurate when bracketing areas for large excisions.